I'm Maria Wellisch, and I'm a registered nurse, and I'm also a licensed nursing home administrator, and I'm really excited to be able to present this Training Delivered to You program today. Let's begin with talking about dehydration. And very simply, I looked at a lot of definitions on dehydration, and some of them were very complicated, but very simply, this is the amount of water that's leaving the body is greater than the amount that's being taken in. That's all you have to understand initially for dehydration. Much more involved for nurses when they have to get into electrolyte and electrolyte imbalances. But basically, you have for dehydration, more water is leaving than is coming into the body. I can't stress enough before we start this program how serious a problem in long-term care facilities, assisted living facilities, and other places this is as a problem for our residents and for the community at large. This is not limited to just long-term care. All of us, from birth to death, are affected by dehydration, but we are especially susceptible when we're in a long-term care. 1/3 of residents in long-term care facilities experience a dehydration episode in a 6-month period. I'm going to say that again. That is so important. 1/3 of residents in long-term care will have an experience of dehydration. Can you imagine? And so when you look at this across the amount of a year, we have to be so attentive to this, and hopefully we'll make an impact with this program today. I want you to understand that we always teach about dehydration in long-term care facilities, assisted living, adult daycare facilities, senior centers, how important fluid rounds are. But this is way more than just pushing it through and putting out fluids. It really is about consumption and why people consume and why they don't and what are the ramifications. So I'm delighted if you have a fluid card and that you make fluid rounds, but I want you to really understand why we're doing this. How serious is this problem? Well, the most serious consequence of dehydration, unfortunately, is death. And dehydration is now and has been for a number of years considered a sentinel event by CMS. And anybody who works in a long-term care facility knows of other sentinel events like impactions. But we don't always think about dehydration until somebody's admitted to the hospital as a sentinel event. But any time this is diagnosed, you need to know and be aware that CMS looks so closely at this. And we're doing this because it's so important to our residents above all. I thought this was real interesting in an article I read that they did 4 major categories for hydration habits for residents in long-term care. And remember, whenever I talk about long-term care, this relates to other folks as well. So we're not limited to just nursing homes. But it's divided up into can drink, can't drink, won't drink, and end of life. And can drink is that people are able to access and consume the fluids, but they may be cognitively impaired. They may never have been somebody who took a lot of hydration, and they don't know the importance. And some of this relates to habits. Can't drink is they're physically incapable of accessing the fluids. So this could be somebody at home who can't get out of bed. This can be one of our residents who can't reach the water pitcher. And this can be somebody who can't safely consume liquids, and there we've been talking about dysphagia. So can drink, can't drink, won't drink. And this is one of the most interesting of ones, and there was a lot of literature on this, about how many people will decide not to drink because of urinary incontinence. And they don't want to have these episodes, or they don't want to have to get up during the night to toilet, so they start restricting fluids very early in the day, and it's something very embarrassing and they don't talk about. And then, of course, there's the end of life or the terminally ill residents or just community dwellers. But I want to talk about that a little bit later, and I have a whole slide on that because I think that's important for us all to consider as well. So when you're thinking about hydration habits, those who can drink, can't drink, won't drink, end of life. So what are the causes of dehydration? And we can talk a lot about this, but I'm not going to do that today because I think many of us are aware of these, but I just want to run through them so that we're sure that we cover them. Number one is that we know that one of the causes for dehydration is just simply age. After the age of 85, we see even a greater increase in dehydration. there is a decreased content of body water as one ages. And I'm not sure people always understand this, but this is because we're replacing muscle mass with fat cells, and that affects how we metabolize and how we handle things in our body. I'm going to be doing a program in June that will be for nurses, and I think at that point we'll get into electrolyte imbalances and what's happening there, but I think it's very important for people to understand just a basic idea of exchanging fat cells for muscle cells. We all know that have worked in long-term care, but many people who have not do not understand that there is a decreased thirst mechanism when people age up. And that actually can be hormonally induced, but I want you to know that the most important thing is, as we get older, our desire to drink, our need to drink, our knowledge that we should be drinking is reduced. The physical or mental inability to consume fluids, and we'll be talking about that when we get into a little bit more about dementias and cognitive and some stroke issues. Depression, alteration in mood, and I guess, again, our cognitive status all affect our dehydration status and causes for dehydration in the elderly. There's some more, and I want to talk to you about renal changes. We all know that as every year goes on, there are some people who never have renal changes, very minimal at most. But for many people aging up, we see major changes in their kidneys and their ability to filtrate and how the kidneys work. Dysphagia, I can't speak about enough. The difficulty in swallowing is another reason for dehydration. And it isn't just that they're having difficulty swallowing. For any one of us that have ever had to use thickened liquids, I would just ask you, have you tried it? If you have not tried thickened liquids and you're working with seniors that have to consume thickened liquids in order to be able to swallow safely, I think you should have to try it to be able to understand. And I really encourage people to take a sip and see what that's like. Poor dietary intake, we'll talk about in a minute, because a lot of people think that if you're eating poorly, that isn't going to affect your fluid. That's not true, and we're going to see that with some vegetables and other food sources in a minute. The lack of available fluid is always something that's important. And I want to talk about here, this is the picture that all of us see in hospital rooms, in assisted living, skilled nursing. We always see these fluid containers. I could get a whole lecture on these just in regards to infection control and handling ice. But the bottom line is, without fresh water and without having it available, and we keep talking about, do you have it at the bedside? Is it within the reach of the resident? If it is not, the person cannot consume. And they may not even think about asking for a drink of water if they don't see something that triggers their thought that they might be in need of more fluids. We're going to talk about warm environmental temperatures only for a second, because I think most of us have been very well and very made knowledgeable that as the temperatures rise, we have an increased chance for dehydration, even heat stroke, as the temperatures rise. I can tell you in San Antonio, Texas during the summer, we're very concerned and have frequent announcements on television and bulletin boards around town to prevent environmental temperatures rising so high and people not having adequate hydration. I do want to mention here that dehydration is not just something that happens in the elderly. This starts, we all know, if you have babies. How concerned we are when a baby doesn't drink enough fluids. It's no different for elders, and all in between, every one of us need to be drinking enough fluid. So what are some of the important contributions or factors that create inadequate hydration? And that is fever, infection. Most of all, the closest one that we have to watch above all, maybe you shouldn't say that, but we know the fastest somebody will dehydrate is from vomiting and diarrhea. Excessive activity, and people will say, well, when we're talking about the elders, what do you mean in excessive activity? Just because of somebody's age, being outdoors, being gardening, whatever, can lead to dehydration. But I want you to remember about folks who are in our assisted living, long-term care facilities, especially with dementia, that have excessive locomotion. We talked about that when we did our program on elopement and how that is purposeful behavior, but something we really have to watch. And in this case, we need to talk about when somebody is wandering or walking round and round and round the facility, are we making sure that we're giving those folks even extra fluids? Excessive perspiration, we don't usually see this a lot in seniors. It's something that it's not that we never see it, but it's not as common. And something I think people really don't think about is wound drainage. And when we see somebody that has a pressure sore or has a small burn, even skin tears, you can watch the fluid on dressings. We have to be very, very, very attentive to fluid loss from wound drainage. All right. So what are some more contributing factors? Medications that cause fluid loss. So we're going to talk about here diuretics. We need to be aware of those things. And we need to let our staff know. I know every time I teach a class, I talk to the nurses, I talk to folks about, are you letting your staff members know what medications people are on that they should be watching for? And one of those is, when we're talking about meds, is any of the diuretics. And if they're having fluid loss and they need replacement, or are we doing and watching that somebody not get too much fluid, and we'll get into that with intake and output in a few minutes. Other contributing factors to dehydration are somebody who's on a tube feeding, uncontrolled diabetes, shortness of breath and mouth breathing, or anybody on a ventilator. Wait till you see these statistics in the different slides. And all the literature talks about if people are receiving enemas, you must be thinking about fluid replacement for these folks. So, can we identify residents at the greatest risk? Can we? Well, there's a lot of question about this. We know some that we definitely can. And one of the issues is here is somebody female, they say they're at greater risk. The literature and evidence-based practice is beginning to narrow that, and I don't know why, neither do they, but I can tell you that being a female has in the past been noticed as putting people at a greater risk for dehydration. A bedridden patient, anyone with an acute illness, anyone 85 years or older, a resident that takes 4 or more meds per day. Now think about when we talk about polypharmacy, we're talking about even more meds than that. But in this case, they're saying when you're looking at a risk for dehydration, we're looking at just 4 meds. And we know most of our residents take way more than 4 medications. And 4 or more chronic illnesses for sure puts people at a greater risk. So, do you use a risk assessment tool to look at assessing someone for dehydration? This dehydration risk appraisal checklist covers everything from the, are they a female? They do a BMI, they talk about dementia, depression, CVA, diabetes, urinary incontinence, and all the way through it goes into medications, more than 4 meds, laxatives, diuretics. We'll talk about psychotropics in a minute. Intake behaviors, do they require assistance to drink? Do they have difficulty swallowing? And it actually, I believe it's 31 questions. The original tool was developed by the VA Association. But I can tell you that this tool has been limited to 31 items, really quick to do. And I will tell you that this ties in very closely to the MDS for those working in a skilled nursing facility, very closely, and gives you lots of information. And it is a tool that will help your CNAs, will help the nurses, help the entire staff, and more importantly, even your dietitian, to have this upon any one of these events that we've talked about that contribute to dehydration that we know, but a good risk assessment tool, and this is one that's based on evidence-based and best practices. So you have a copy of it, and you can download it after the program. All right, we're going to talk about signs and symptoms of dehydration. And the signs and symptoms of dehydration are some that we're all taught, and some that we're not taught, and some that we just forget. So bear with me for a few minutes as we go through these. Signs and symptoms are sunken cheeks, but if the person always had that pallor or is very thin, these may not be the easiest of signs. Sunken eyeballs. They talk about dry brown tongue and dry mucous membranes. I want to tell you that I tried to get a good picture, and I'm sure they're available, but I couldn't find one on the brown tongue, but I'm more interested in the tongue fissures that you can see that come from dehydration. It almost looks like cracks in the tongue. There's no reason when you're working with residents, you're going to do their oral care or assist someone not to ask them to show you their tongue and look for those fissures and see if you happen to have any one of those 1/3 of people who might be suffering from dehydration. The other thing about the mucous membranes is we say dry, but in a lot of cases it's very sticky. And I think people like myself who are under hot lights teaching, and when you don't want to drink a lot of water while you're standing here because you can't leave, your mucous membranes, you can feel your mouth almost get sticky, not so dry. And so those are some things to look at also, not just looking for the dryness. When they talk about dry, inelastic skin, at the very end I'm going to show you some photos, but I want you to understand that as people age and they lose collagen in their body, their elasticity changes. So where I would pinch my hand and it might go right back down, somebody who's older, already their skin is very loose. So this may not be the best way of checking for dehydration. Weight loss, for sure, we always think of is just in relation to nutrition and into food intake, which I said we would get to, and I promise we will. But weight loss has to be looked at as could this be from dehydration. Concentrated urine is really interesting. When we talk about concentrated urine, there are studies that are done, and I don't know whether anybody has seen these studies or used these, and if you do, please tell me. But there are little wheels that do from like a straw-colored urine all the way to a very dark-colored urine. And they use these sometimes for folks when they first come into facilities to establish what their baseline is. They have not been shown to be 100% effective, but one of the things is we do want to be looking at the color of urine and notifying changes and notifying supervisors and nurses, because even if they have decreased urine output, that's one thing, and that very concentrated urine may be giving us a heads-up sign before they have almost no urinary output. But anybody who's interested in learning more about the wheel can contact me, and I'll try to get you that information, but it was an interesting study for me. Another sign and symptom of dehydration is constipation and impaction. And you have to have so much water or fluid consumption in order to be able to have stools that are going to be able to be passed easily, and so that we don't suffer from the constipation. And of course, by the time we get to an impaction, again, we have a very serious situation for somebody who's older. And looking at impaction is why that is a sentinel event, and dehydration go right hand in hand together. So more signs and symptoms: nausea, anorexia when somebody quits eating may be another sign. And then we're going to talk about abnormal lab values. And for that, I have another form that I think I do, available to show you. And again, this is available for you to look at. And this is hard to see, but for, at least for me. But I want you to know that you can look at all of these approximate ranges or values for your laboratory tests for hydration status. I think this is just a great thing to copy off today of it and put it up for your nurses to see and to have them look at when people are coming back with some of their lab values. We should be catching this stuff faster than anybody else, and this is just one way to do it. All right, so signs and symptoms. This is really interesting for me to talk about for a minute, and that is with postural hypotension. If somebody doesn't have enough fluid in their body, and this is something so important to look at when people are on antihypertensives, when they are on diuretics and other drugs, when we say we need to look for postural hypotension. For those that didn't join us for falls, and I encourage you to go back and look at that program, but when you look at falls, we ask that anytime somebody's had a fall to take their blood pressure and to see if it's different when they're laying down and standing up. Preferably laying down, then sitting up, then standing up. 5 minutes apart is how often the time duration between taking them. If somebody has a significant drop in blood pressure, they may be dizzy, that may have been the reason for the fall due to medications, or it can be due to dehydration. So we're talking about postural hypotension or hypotension, which is just a low blood pressure. We never think about when the person falls, did they drink enough? That tends to be the last thing on our mind, is when somebody has frequent falls, are they well enough hydrated? Or is this a symptom of dehydration? So something new to learn, especially in regards to falls, but across the board for dehydration. Are we checking people's pulse? Because if the pulse rate is going up, the body tries to compensate for the lack of fluids, and so the pulse rate is going to rise. And I really encourage you to teach the CNAs, and if you are a CNA, to take vital signs whenever you feel that somebody just isn't acting like themselves. Because a full set of vitals tells us a lot, and one of those is the person dehydrated. Of course, we know about elevated temperatures, but I think this is a point that I want to bring up to you that I think is so important. With an elevated temperature, a body temperature, we tend to think about anything over 100, 101. I want you to know in seniors, we have to look very differently. If somebody has a 97 normal baseline temp, and all of a sudden they mount what we would consider low grade of a 99 temp, that's a 2-point increase. Their body is working very hard, and it is signaling to us something's going on. So when we take temperature, we also want to be looking at not just infection, but are you thinking about dehydration as well? When you see somebody who's dehydrated, they're normally going to have weakness, and it's interesting that that weakness comes in the upper body. If you remember, when we have frequent falls, we look at weakness in the lower body. When we look at dehydration, the weakness may be seen in upper body strength. Mental confusion is so often confused with, and we might talk about this a little bit more when we get to medicines, but we think, well, is it a change in cognition because they're developing dementia, cognitive inabilities? Are they confused because of the medications they're taking? And are we looking at those med lists? But do we often stop to think, could they just be mentally confused because of what's happening in their body with their fluid volume and dehydration and what's happening to the brain? For the nurses this summer, I want to tell you once again, when we bring up our program, I was amazed at learning more about mental confusion and the electrolyte imbalances in the studies that I've done on this. Even more signs and symptoms. I know it feels like they just don't end, but if there's greater than a 3-pound weight loss within 7 days, don't look just at their appetite, look at their fluid and their thirst, because they may not mount a thirst mechanism or a thirst response at all. If you see delusions, dizziness, delirium, yes, we want to assess everything, but we want to make sure the person is well hydrated. And this is our responsibility. An unsteady gait. Are we looking near enough at fluid values, fluids intake when we see people having falls? How often do you have somebody complain of a headache that we're very quick to go get a Tylenol for them, but we're not checking their urine concentration to see, are they putting out dark urine, asking them how many times have you urinated today, seeing are they eating enough that they can get those fluids. So I want you to think about now a little bit different when people complain of pain. Yes, we want to always treat pain. It's whatever somebody says it is. That's a whole nother lecture on pain. But headaches many times are the result of dehydration. And then there's a flushed appearance. And I do see this a lot in the summer with our folks, and that always concerns me when you see somebody who flushed and gets that red face or pink little cheeks. I think more than anything this tells me about baseline. Learning who your residents are all the time so we notice these differences when they happen, and then our interventions that we'll talk about in a minute. But these are signs and symptoms we're looking for. And we've gone over a ton of things that are signs and symptoms that we should be looking for. And I want you to know that by the time that we notice these signs and symptoms, many times it's too late for these residents. We have to recognize and make hydration something is preventative, not something reactive to these signs and symptoms. We want to prevent all of those, because the truth is this is something that creates a morbidity and mortality. And I don't have the exact numbers, but it's 50% of the people that have a hospital admission that were under Medicare will die within 1 year if they were put into a hospital for dehydration. So there's, I'm not going to say there's never an excuse for dehydration, because that's not true. There's so much going on physiologically, but there's so much we can do to prevent it. The minimum fluid needs to prevent dehydration. This is really interesting stuff. If you look at the daily requirements just for our intestinal tract, we need 125 cc's of fluid. Breathing takes up 335 milliliters. Our lungs, when we talked about earlier, how much fluid do we need? 500. The skin, 500. So just think if you have a loss, let's talk about open skin areas, whether it's pressure ulcers, skin tears, wounds, incisions, anything where there's a loss of fluid from the skin, 500 cc's. That's for normal skin. That's not with the other wounds. And our kidneys, 1,375 milliliters. And this is pretty profound numbers when we think about how much fluid we need to be encouraging people to take. So, fluid intakes includes all fluids consumed. So that's all the fluids on meal trays or all the fluid in your daily meal. This is fluids given during a med pass and fluids consumed during activities. We're going to talk about activities in this for a minute, but I'm going to ask, and I don't think I said I was going to do it here, but I'm going to ask if we can switch over and look at these cups for a minute. I see in front of me 5 different cups. Hope I counted right. Yes, I did. You'd think I was drinking. We have 5 cups here, and I want you to know that every one of these cups can be used when we pass meds or when we give fluids for breakfast, lunch, dinner, for our different times of the day that we are providing fluids during our fluid rounds. And we have our folks who are recording how much fluid somebody's receiving. I would ask you if you know how much fluid would go into each of those cups. It is suggested in best practices that every cup you have in your facility, whether it's a coffee cup, a fluid cup, a medicine cup, whatever, that you have a picture of it and that you put up how many ounces are in a full cup. And I think that's a great best practice because I think even for myself, it's only when I buy the bottles of, I guess you're not allowed to use names because I have no one, but I buy the pre-bottled water, and whether it's 8 ounces or 16 ounces is how I keep track of how much fluid, and without that I couldn't tell you. But just ask your staff, and this would be an interesting experiment to do, is to take those cups, line them up, know how many ounces are in them, and just ask people to guess and see and have a prize for whoever wins that knows exactly, because most of us don't. And I would say without those measures to bring it back to our attention, to be looking at and putting up that picture, how are we measuring intake and output? So thanks. All right. What is the effect of food on hydration? Well, this is really interesting because when you think about the foods we eat, how much water is there? And I have lists and lists of the amount of fluid in different types of things. And this is why we work so closely with our dietitians to help us in planning meals, because they know how much fluid is there, how much protein, carbohydrates. But I want you to look at this, that lettuce is 96% water. Asparagus, 92%. This is a great point to make. It's kind of a conflicting point, but I want to tell you that when you think about asparagus, and I'm looking at this, and we talk about urine concentration, do we know what foods discolor urine? Asparagus happens to be a food that does discolor urine. And so you might see a darker brown or greenish colored urine if somebody's eaten a lot of asparagus or even a little bit of asparagus. And so you can't always use the concentration unless you know what people are eating as well. We're going to talk a little bit more about the effect of food on hydration, but I really hope you'll look at and have knowledge about how much people, when they eat, for intake and output, that we're putting down what they eat. Because it's not always, if everybody ate only lettuce, they may not be getting much nutritional value if it was an iceberg lettuce, but they sure did get a lot of fluid. All right, going on. Medications. The body uses water as a diluent and as a vehicle for medication. And what does that mean? It means that the medication can really build up and become toxic in a resident who's dehydrated. And I don't think we think about that near enough. When I see nurses doing med passes, and it doesn't matter what facility, sometimes I see that all they do is give them enough water just to get the pills down, but they don't stay with them to make sure that they are completing the entire cup of water or encouraging that. And we need to do that because that is part of the total fluid intake for the day. Diuretics we talked about, we have to know. We have to know about people who are on laxatives because we want to be encouraging fluids unless it's being restricted. Med passes, one of the things that's important, we've talked about the size of the cups, we've talked about having the resident drink all the fluids that's required and including this in their intake and output or their plan for adequate hydration. But what I want to know is how many of you have a policy in your facilities and you're consistent with it with how much fluid is being used with each med pass. So if it's 4 ounces, 6 ounces, 8 ounces of fluid, do you have a policy telling you how much fluid the resident should be taking in? Because if we're including that in I&O and you've done 2 med passes on the day shift, we need to know what that amount is. Okay, the best part of this is there are interventions that we can do and things that we can do to make hydration more creative, incentivize our residents and family members to drink more, and even ourselves, because we all need it. What I want to tell you about here is that when I see a water pitcher, like you saw the picture earlier, most places it's a pink pitcher with a lid, not very appetizing to want to have water out of. But when you see a clear pitcher and you see slices of lemon in that, you see cucumber in that, something with ice cubes to pour, I have to tell you what an amazing thing to have. It makes you more thirsty just thinking about it when you look at it. Some of the interventions that I think are great is having happy hour, and happy hour does not have to involve alcohol. Happy hour can be that you can have fluids available, have lots of juices, you can have water, you can have sparkling water, you can do all sorts of things to have good interventions for hydration that can be more creative. Tea parties are a wonderful thing in the late afternoon for some of our folks, is to have a tea party for the ladies. Maybe even the gentlemen would like to come. Some more creative ideas, and this one just makes me thirsty and it makes me want to have one of these for me, but look at this of popsicles. No one said that popsicles were not appropriate for our residents, that they can't have them. We can get sugar-free popsicles, and we can have them very tasty. Lots of different flavors. What a great thing to do on an afternoon. And it doesn't even have to be summer. You can do it in Alaska in the winter or the cold of summer. But I want you to know we have to think of new ways to get people involved in hydration. You got to work with your dietitian because we have to know what the residents like and what the residents dislike. Go back to your initial assessment that we talked about and make sure that you're letting your dietitian know this. And also it's great for your MDS nurses to know some of those likes and dislikes and put those on service plans and care plans. Beverages and snacks with activities I want to talk about for a minute. So many of our snacks are like cookies and cake and other things. Let's go back to the picture with popsicles and different things that we can do, like these jellos look beautiful to me. We want to look, when we're looking at hydration, of not spoiling somebody from eating high protein with eating cake, but maintaining their adequate hydration. Can we do a better job with what we're putting out with activities? Always talking about interdisciplinary stuff that we're doing, interdisciplinary teams. And so I think this is a great area we can all work together, the dietitian, the activities coordinator, and the nurses, for what we can do to be more creative in better hydration of our residents. Intake and output monitoring is for any resident who's receiving tube feeding. That is required. Residents with Foley catheters, residents with urinary tract infections. If a physician orders I&O monitoring, residents with known dehydration or at risk. So if you did the risk assessment, the MDS nurse puts this on to your care plan, you get it into your program to put them on I&O for your treatments and know that what's going on. This is so important. Certain kidney and renal conditions, and every resident who's receiving IV fluids should be on I&O monitoring. Intake and output monitoring for any resident with a fever, any resident vomiting, diarrhea, even with a non-febrile infection, and any unexplained weight loss or weight gain. I think we really made that clear. Even though we look at how much they're eating, do we always look at how much they're drinking when we're thinking about I&Os, when we're thinking about putting in our numbers for how much intake? Yeah? We get that down pretty well with percentages, but we may leave off what they're getting in fluids. Some special notes that I want to get in are about antipsychotic medications. And I did not or have not had a lot of training about antipsychotic meds blunting the thirst response. Other people may have a lot of knowledge about this, but I know how important it is that we get all the consents for meds when we're going to use antipsychotic meds, how we want to avoid using them. But I wonder, for all those that are being used, are we really thinking about and telling the CNAs to increase fluid intake if it's appropriate and the physician says? Again, I want to talk about the poor palatability of thickened liquids. And this is a very interesting fact, but NPO fasting, they're saying in the current literature, is that we have seniors staying NPO way too long. And it's having an adverse effect on their healing and recovery from procedures, even outpatient procedures that we have them fast for. This is something that we need to be really looking at in regards to even fasting that we do for blood work when people come in. If the labs don't come in early enough, if we're taking a mother, a father, a person out for items, when they return, are we thinking about making up for some of that lost hydration? There's also some studies that say that they only need to be NPO even before anesthesia, not having solid food from midnight on, but they may be able to have clear liquids up to 2 hours before. I would not address that personally. That is a physician, but no question about it, the literature is so clear that we have to treat seniors who are going in for procedures and being put so they can have nothing by mouth before the procedure to be able to have liquids as soon as they return, and making their appointments as early in the day as we possibly can. End-of-life issues. Our withholding fluids at the end of life is still a very, very, very controversial issue, and we're not going to be able to address that today, other than to say this is an ethical decision. Proponents of this say that dehydration in the terminally ill is not painful, that it lessens excessive pulmonary secretions and nausea and edema and pain even. Opponents to withholding fluids at the end of life say that the associated symptoms of dehydration, such as confusion and delirium, are stressful. They reduce the quality of life for the person. We're not going to answer this question today. There is no perfect answer, but what I will tell you is this is a decision that needs to be made by the individual themselves, their families, and their physicians, but something that we really need to be cognizant of. Residents with dementia forget to drink. They need queuing. They may consume more sweet fluids than plain fluids, and we need to make sure that we're providing those, the popsicles, juices that someone likes, again, preferences. And we talked about the excessive locomotion and need for more fluids. Residents with physical disabilities. I bet there isn't one of us that hasn't walked by somebody who does not have the capability, either cognitively or physically, to open a milk carton, to tear the tin foil off of a juice container, to open the containers that are on the plates there. So difficulty opening containers is huge, and we have to look at that. So remember, you know, these were people who won't drink, can't drink, can drink, and end of life. This would be one where somebody can't drink because they can't open the containers, could be a cause for dehydration. And these are here as links as well, and you can go to them. This happens to provide the picture that talks to you about how to look at dehydration, and this gives you a sign of skin turgor, an article that was there you can look at. MedicineNet.com had some wonderful information on dehydration, and I say this to you because who's ever watching this should be teaching someone else about dehydration. Whether it's a family member, whether it's a group that you support, whether you go to a senior center at your church, this is something that we can do to keep our bodies healthier. And I mean, this is a whole subject, folks, that takes way more than 1 hour to get it all in, and I'm so excited we're getting this much in, but there's so much to learn about this. And now I want to show you one that you can show to your own staffs, to family members, and if you go directly to this site, you'll be able to do this. So it's going to come right up, but I want you to see here that this talks about your body and what it's made up with water. It goes into how much water we lose and how routinely. It talks about diarrhea, constipation, vomiting, It takes you through children and sweating and about diabetes, and it's very simple, and you can put this up and read it or just send it as a link to someone else. This is really for the public. There is so much free good information on the internet. I can't say enough, and whenever I find things that I think are good, I always want to share them with you. So this just happens to be a picture of somebody who has a burn on the top of their hand. Great photo for us to look at to think about how much fluid is lost when we have a break in the skin. I thank you very much for joining us. We look forward to seeing you, and have a good day. Thanks.